A very good evening to everyone. I am Faraz from Clarnet. And thank you so much all doctors for watching the video. And Clarnet is very proud to be a part of this session as a digital partner. You all are requested to visit our website www.clarnet.com, where you can watch lots of live sessions conducted by expert doctors across the globe. And we have MedWiki service, which is a medical Wikipedia for doctors only that you can read. By taking not much time, I would like to hand over this session to Dr. Jayashri Sood, ma'am, CEO of ICA. Over to you, ma'am. Kindly proceed from here.
Thank you, Faraz. Good evening, everybody. Sorry for this. You may not be able to see me properly because I'm still on my way home. Welcome you all to the series of our ICA webinars, which we have crossed the century a couple of weeks ago, and we are way off after that. And just wanted to tell some of the people who may not be knowing about these, that we are these webinars every Wednesday regularly since 2 years, more than 2 years, and we cover different topics of interest. Initially, we started with simple seminars and just the discussions and lectures, but gradually we have expanded over the years, and we have started including PG's discussions, debates, quiz, which has been very highly appreciated by all the students, and we get very positive feedbacks. All our lectures are uploaded on the YouTube, and they can be seen free of access, no access problems, and they can be seen freely the subsequent day onwards. So this is the things that I would like to tell about ICA. We are completely academically oriented and always are keen to promote our activities. The conferences, we've been having national conferences every year. Again, this has been done consecutively without any break. And this year, we are going to be holding the ICA Con, as we call it, in November, the first week of November. And this will be the 13th annual national conference, and along with the third international conference. It's from 4th to 6th November, as you can see here, being organized by the Government College of Anesthesia in Sector 32, Chandigarh. And I can assure you, seeing at the photographs over there, definitely everybody will be tempted. The program, lectures, orations, panel discussions like we have in other conferences, but of course we have expert faculty who are participating. Coming to, of course, the sightseeing and the registration, you can see here. And I think today actually was the early bird. This has been extended to 31st of August, and maybe the students could all register tonight. Of course, the workshops are very interesting and you could all look at it. Coming to today, but today is a very, before I come today, next week, Faraz, please change it. Next week, which is the next episode, which is going to be the 112th episode, will be the forthcoming challenges in anesthesia, where we have very interesting topics where Dr. Mukul will be moderating, following by the anesthesia delivery and anesthesia education as the main topics. This would be next week, same time. And today we have yet another very interesting program on thoracic anesthesia, especially for the students and of course for those people who do not have access to tertiary care centers. There's a lot to learn today, and the ones who may be practicing but do not really have access to good teaching about this, and we could not have a better hospital or a better faculty who are going to be conducting this. And we have several lectures, of course, and the moderator for today's program is Dr. Sangeeta Khanna, a very senior anesthesiologist, and we all know her very well. And just for the formality introduction, Sangeeta is the director at the Medanta Institute of Critical Care and Anesthesiology. And the area of interest, of course, are transplant, robotic, and thoracic. And she is managing many operation theaters and, of course, the anesthesiologists under her. And she has several publications. She is a DNB examiner, past president of ICA Haryana, and of course, she's also a fellowship FICA from the Indian College of Anesthesiologists. So now I shall hand over the mic to Sangeeta to please moderate and start the webinar. Thank you very much.
Thank you, ma'am. Thank you for such a generous introduction. So we begin today's webinar on thoracic anesthesia, for which we have 4 interesting talks along with our speakers who are all senior faculty and along with me in the department for many years. Our first talk for the day is going to be pre-operative workup for a patient who's coming for thoracic surgery. And this will be given by Dr. Preeti Mittal, who's a principal consultant with us. Her areas of interest include airway management, thoracic surgery, and she is also, got the European diploma from anesthesia and critical care. She's passed that exam. She has many publications and awards to her name. So over to Preeti for your talk.
Thank you, ma'am, for your kind introduction, and thank you, Jayashree, ma'am. So my topic of discussion. Yes. So I will be talking today about preoperative pulmonary evaluation for lung resection surgery. So all of us would agree that a good pre-PAC assessment before any surgery, major or minor, reduces the incidence of perioperative morbidity and mortality. This is more imperative in thoracic surgery patient, which falls in the category of high-risk surgeries. So the purpose of the preoperative evaluation is not just to clear the patient for elective surgery, but to evaluate and, if necessary, to implement measures to prepare high-risk patient for operation. So the objective of preoperative evaluation is risk assessment, where we assess for the increased risk of respiratory morbidity and mortality in these patients. And then we institute measures to reduce the risk in the post-operative period. So in pulmonary thoracic surgery patient, it is very important to assess that after the surgery, patient will not become a respiratory cripple or a ventilator dependent patient in his post-operative period. And the second most important point is that we need to evaluate these patients for pneumonectomy as well, even if the plan is to go for a lobectomy or a wedge resection, because things may go wrong and patient might need a pneumonectomy. So we should have a fair idea that in that scenario, what will be the post-operative outcome of the patient. And moreover, the consent for these surgeries are always taken for a pulmonary resection. Consent is never taken for lobectomy or pneumonectomy. Consent is always for a pulmonary resection. So patients should be evaluated for a pneumonectomy as well. So traditionally, the pulmonary assessment is done by a 3-legged stool, which involves assessment of a respiratory mechanics, cardiopulmonary reserve, and assessment of lung parenchymal function. All these 3 parameters are important. Otherwise, the assessment won't be complete. So like if we are getting good results in one parameter, we should not think about that there is no need to go for the other 2 parameters. For when we perform a pulmonary function test, it is very important that the quality of the patient performance and test reproducibility must be optimal and should conform to the standards. Patient should be given clear instruction how to perform the test. He should be given 1 or 2 rehearsal before taking the final readings, so that we have the best result for that particular test. And then the special attention should be paid to understanding the cause of the abnormal result, like a reduction in FEV1 due to weakness, which may, like in case of a myasthenia gravis, may be associated with a different surgical outcome as compared to patient with COPD despite identical airflows. So this is how a pulmonary function test is done. There are various guidelines given by various societies. Guidelines are being given by American College of Chest Physicians, British Thoracic Society, and European Respiratory Society. So let's take a case. A 78-year-old male smoker comes with a right upper lobe mass and was confirmed as squamous cell carcinoma on FNAC. CT scan was done, which confirmed the chest X-ray finding. There was no enlarged lymph node or pleural effusion. It was an early cancer, so a plan for right upper lobectomy was done. PFT was done, which showed a FEV1 of 1.27 liters. So now the question is, can we clear this patient with this pulmonary function test for surgery? No, because we have just assessed one leg of the three-legged stool. We need to perform other tests as well. We need to order a DLCO. So this is a setup for performing a DLCO. This is a carbon monoxide cylinder. So a DLCO was done for this patient and it was 72%. So now, can we now clear this patient for surgery for right upper lobectomy? No, because this patient again needs calculation of percentage predicted FEV1 and DLCO. So the recommendation by ACCP is that all patients for lung resection should have an assessment of FEV1 and DLCO and then calculation of percentage predicted post-operative FEV1 and DLCO. So initial recommendation was that if there is no evidence of either undue dyspnea or exertion or interstitial lung disease, and FEV1 is more than 80% predicted or more than 2 liter, patient is suitable for lung resection, including pneumonectomy, without further physiological evaluation. And if FEV1 is more than 1.5 liter, patient is suitable for lobectomy. Now they have changed, the recommendation has changed, and it is recommended that absolute values are not good enough to assess the 30-day mortality and post-operative respiratory failure. So the recommendation is to calculate the percentage predicted post-operative results, and which correlate significantly with prognosis, and it is recommended that percentage predicted rather than absolute lung function values should be used in assessing patient for lung cancer surgery. So the correlation between FEV1 and DLCO is very poor, and it has been found that more than 40% of patients with FEV1 of more than 80% may have a DLCO of less than 80%. So they are like, both the tests are needed before we take any decision on the patient post-operative outcome, or before we can prognosticate the patient for post-operative period. This post-operative designation is used to indicate that the estimated parameter refer to late post-operative period, that is 3 to 6 months after the surgical procedure. So we cannot expect these values in the immediate post-operative period. In the immediate post-operative period, expectation is that the values will be much poorer, or the FEV1 or DLCO will be much less, which we are calculating. So as per the ACCP 2013 recommendation, if FEV1 and DLCO values are more than 60%, no further test is recommended and the patient can be cleared as a low risk case. Whereas ERS, or European Respiratory Society 2009 guidelines, says that if the FEV1 and DLCO value is more than 80%, then only he can cleared for a lobectomy, for a surgery. So there is like wide variation in the recommendation by the various societies. So the calculation for predicted post-operative FEV1 and DLCO is done by anatomic method. For this, predicted post-operative FEV1 is equal to pre-operative FEV1 into 1 minus Y by Z, where Y is the number of functional or unobstructed lung segments removed. It is very important to understand that we will take into account the lung segments which are functional and not obstructed. If we this should be discussed with the surgeons, CT scan should be seen properly. If the lung segment which are being planned to be removed are non-functional and non-obstructed, there won't be any change in FEV1 or DLCO. And the percentage predicted FEV1 is taken as a percentage of the predicted normal FEV1 or DLCO. So this is how the lung segment counting is done. For the right lung, upper lobe is 3, middle lobe 2, in lower lobe 5. For the left lung, upper lobe and in lower lobe are 5 and 4. So based on these, calculation for the predicted post-operative FEV1 was done for right upper lobectomy by anatomic method, which was 57%, and DLCO percent was 62%. Now the question is whether now we can clear the patient for surgery. So we have already discussed that an assessment for pneumonectomy is also needed. And based on these findings, we cannot clear the patient for pneumonectomy. So we need further tests and we will order a perfusion scan. So for perfusion scan, a quantitative radionuclide perfusion scan is performed. Either a ventilation or a perfusion scan can be done to calculate the post-operative lung function. There is no benefit of doing both the tests, and most commonly perfusion scans are done. Ventilation scans are not commonly done. So in the similar manner as we have done by anatomic method, we will calculate FEV1 and DLCO based on perfusion studies. So this is the lung perfusion scan, and this patient, the same calculation was done for his predicted post-operative FEV1, which was 61.2 for right upper lobectomy by perfusion method. DLCO percent was 66.6% by perfusion method for right upper lobectomy. For right pneumonectomy, the values were came out to be 35.6. and DLCO percent came out to be 38.8. So this is the summary. So in summary, for right upper lobectomy, values were close to 60%, whereas for right pneumonectomy, values were less than 40%. So this patient is low risk for right upper lobectomy, but need further assessment for possible right pneumonectomy. So what we will order, we will ask for exercise test. So exercise tests are to stress the whole cardiopulmonary system and estimate the physiologic reserve that may be available after surgery to predict the risk of post-operative cardiorespiratory complication after lung resection surgery. And it is a predictor of long-term exercise capacity. So there are few low technology exercise tests which are available. One is stair climbing test. Stair climbing test is a first line functional screening test to select patient that can undergo surgery. Height of ascent should be more than 22 meters. The major limitation of this test is there is lack of standardization. Then there is a shuttle walk test. Shuttle walk test requires that the patient walk back and forth between two markers set 10 meters apart, and the walking speed is increased each minute in a graded fashion paced by an audio signal. End of the test is when the patient is too breathless to maintain the speed. Inability to perform 20 shuttles, which is equivalent to 250 meters on 2 occasions, suggests a VO2 max of less than 10 ml per kg per minute, which is an indicator of very poor prognosis in the post-operative period. Then 6-minute walk test requires the patient should walk on a flat, hard surface for a period of 6 minutes. Patient is instructed to walk as far as possible in a period of 6 minutes, and the in-between rest is allowed. So again, this test there lacks standardization, and the current guidelines says that this test should not be used to select patients for surgery. So the best standardized test for exercise testing is cardiopulmonary exercise testing, and this is the setup in our hospital for cardiopulmonary exercise testing, or CPET. So as per the ACCP guideline, the indication for cardiopulmonary exercise testing are positive high-risk cardiac evaluation, or FEV1 or DLCO less than 30%, or stair climbing less than 22 meters, or shuttle walk test less than 400 meters. As per ERS or the European Respiratory Society, FEV1 or DLCO less than 80% warrants CPET study. CPET, if it is VO2 max is more than 20 ml per kg per minute, indicates safe surgery and up to pneumonectomy. Whereas VO2 max of 10 to 15 ml per kg per minute indicates an increased risk of perioperative death. And VO2 max of less than 10 ml per kg per minute is a indication for very high risk of perioperative death, post-operative death, and it is considered a contraindication to major anatomic resection. For pneumonectomy, this VO2 max is also calculated in the similar fashion. Predicted post-operative VO2 max is calculated in the similar fashion as we have done the calculation of FEV1 and DLCO by perfusion method. So if a patient is a high-risk cardiac evaluation or has a predicted post-operative FEV1 and DLCO of less than 30%, one should straightway ask for a CPET study. But if the values of FEV1 and DLCO are between 30 to 60%, then patient can take stair climbing test or a shuttle walk test. Stair climbing test less than 22 meters or shuttle walk test less than 400 meters, then the patient should undergo a CPET study. So this is how the patient are classified into 3 categories: low risk, moderate risk, and high risk based on their VO2 max. This is the algorithm which is generally used for thoracic during major anatomic resection. So definition of low risk is patient's functional reserve is sufficient to withstand the stress of surgery and can perform daily activity, will be able to perform daily activity in the late post-operative period. The expected risk of mortality is less than 1% and major anatomic resection can be performed safely. For moderate risk, morbidity and mortality rate may vary according to the values of split lung function, exercise tolerance, and the extent of resection, whether the patient is undergoing pneumonectomy or lobectomy. And in these cases, the benefit of surgery generally outweighs the risk, and therefore it is very important that the risk and benefit of the operation should be thoroughly discussed with the patient. In high risk cases, in high risk patient, these are generally contraindication due to high mortality, which is more than 10% after standard major anatomic resection. Considerable risk of severe cardiopulmonary morbidity and residual functional loss is expected, and hence patients should be counseled for alternative surgical like minor resection or non-surgical options. Thank you.
Thank you, Preeti. That was a very elaborate and I think a very good discussion that we have on how important it is to work up our patients before we take them up for surgery. We'll take all the questions at the end. So now I'd like to invite our next speaker. Our next speaker is Dr. Sudhir. He is an associate director with us at Medanta. And his areas of interest include thoracic anesthesia, difficult airway, and robotic surgeries. He also has quite a few international and national publications in place. And he is going to talk about the nuances of one lung anesthesia. Over to you, Sudhir, for your name.
Thank you so much for the kind introduction, and a very warm evening to respected seniors and dear friends. At the outset, I would like to thank ICA and especially Dr. Sangeeta for the opportunity. The topic that has been entrusted with me today is one lung anesthesia. I'll be walking a tightrope. So there's too much to pack in a short time. So without much ado, I think I'll move on to my presentation. So this picture, I'll come to at the end of my presentation, and I'll let know what all tag I put all the question marks here. So the question arises is why we call it a tightrope? Is it really so much of a big deal? Well, I do think this is really a big deal indeed, because the situation here which the patient is undergoing is akin to a situation which a mountaineer is experiencing in the death zone. So a death zone is called when a mountaineer ascends to an altitude above 8,000 meters where there is severe lack of oxygen, and without supplemental oxygen is going to suffer the deterioration of body functions leading to unconsciousness, and may even die in that zone if he spends a lot of time there. So a patient is going to be in this zone for quite a few hours. So definitely he's in the death zone, and unless taken care of properly, he may suffer the consequences. So as we all know, the advances in one lung ventilation have come about by leaps and bounds, and this has led to increasingly thoracic surgeries being conducted in the more inaccessible areas, more complicated surgeries being done, especially with the warts. The traditional teaching has been to ventilate these patients with the high tidal volume with zero end expiratory pressure and a higher FiO2. But with the advent and recognition of the acute lung injury that follows in these patients and a high mortality associated with them, and the increasing VAT surgeries, one lung ventilation has undergone a sea wave of change now. And what now we come to what exactly is happening in one lung physiology before exactly going on to how do we manage one lung ventilation. So what happens in an awake upright patient is the upper zone of the lung is in the upper flat portion of the compliance curve, and the lower part of the lung is on the steep portion. It is more compliant, so it is on the steep portion of the compliance curve. But once the patient goes into the lateral position or is under anesthesia with spontaneous respiration, now the non-dependent lung goes on to the upper steep portion rather than the apex part, and the dependent lung goes on to the steep part. It is more compliant rather than the base of the lung. So the dependent receives most of the ventilation, and the non-dependent receives less of ventilation in this situation. But the situation again changes when a patient is paralyzed. Now the abdominal contents are pushing against the lower lung, and the weight of the mediastinum is also pushing on the dependent lung. So the lung actually comes from the steep part of the curve to now the flat portion of the curve, and the non-dependent lung comes from the flat portion of the curve to the steep portion of the curve. So we have a situation here where the non-dependent lung has the tendency to receive most of the ventilation, and the dependent portion of the lung is going to receive most of the perfusion. So this is as regards the distribution of ventilation. Now, what about the perfusion? The factors that help in better ventilation perfusion matching in lateral decubitus position are the gravity, the effect of the hypoxic pulmonary vasoconstriction, and any surgical retraction. Hypoxic pulmonary vasoconstriction is basically a physiological response of the pulmonary circulature to hypoxemia, and it is the response of the vascular smooth muscle cells, especially in the arterioles and the venules. So they divert the blood away from the operative lung to the non-operative lung that is being ventilated. Any perfusion to the non-dependent operative lung then constitutes a shunt, which may be in the tune of 25 to 30%. Before coming on to the ventilation, I would like to dwell a little on this, on the concept of acute lung injury, around which the whole premise of protective lung ventilation is going to revolve. So this is diagnosed as acute reduction in PaO2 FiO2 ratio to less than 300 with bilateral pulmonary infiltrates on the chest radiograph in the absence of left heart failure. This has been recognized as the leading cause of death after the thoracic surgery, and the incidence of acute lung injury can be anything from 4% in a lesser resection to about 8 to 9% in a pneumonectomy. But the mortality in the patient who suffer acute lung injury can be as high as 25%. So one lung management can influence the incidence and severity of this complication. Multi-hit theory has been proposed for this lung injury, which involves the mechanical stress caused by hyperinflation, cyclical recruitment and de-recruitment, that is epileptic trauma, the release of pro-inflammatory mediators, surgery-related factors, any prior therapy that the patient has received, or other unidentified events like a blood transfusion, aspiration, or things like fluid overload. Now, of special interest to anesthetists is the ventilation-induced lung injury, which is a complex interaction of overdistension, that is volutrauma, increased transpulmonary pressures, that is barotrauma, cyclical opening and closing of alveoli with the tidal volume, that is epileptic trauma, and the release of inflammatory mediators, that is the biotrauma. So this villi can actually exacerbate the existing lung injury, or it may sensitize the lung to further injury. This has literature support also. So lung injury is the leading cause of death because it suffers trauma due to high strain and shear forces. It suffers the oxidative stress. It suffers from hyperperfusion and ischemia reperfusion injuries. So a protective lung ventilation strategy can serve the purpose to mitigate all this injury that the lung suffers. And besides, protective lung ventilation has also been found to decrease the incidence of post-operative pulmonary complications, and so has the duration of one lung ventilation. If you keep it less than 150, probably the injury is less. Now, from here on, I'll go step by step from the time we induce the patient to the reversal. So what happens once we induce the patient, there will be a de-recruitment of alveoli, even in a two-lung ventilation. So de-recruitment happens with the decrease in the FRC or with the induction of high FiO2 or during bronchoscopy. So any recruitment maneuver that we give during two-lung ventilation will have a beneficial effect in the one-lung ventilation period also. Also, once we switch on to the one lung ventilation, we should always give a recruitment maneuver to increase the lung compliance and decrease the atelectroma. We should bear in mind that repeated unnecessary recruitment maneuvers can be injurious to the lung. Another thing that we should do is to ventilate for 2 to 3 minutes with 100% oxygen before going on to one lung. The reason being that the collapse of the lung has been found to be much quicker and more complete, breathing oxygen rather than breathing a mixture of air and oxygen, because the nitrogen is less diffusible and tends to persist for a longer time. Now, once we have put the patient on one lung ventilation, now we have to deal with certain parameters during the maintenance phase. We'll come to it one by one. All of them have found a place in protective lung ventilation. So as Likar et al. Found that as a part of the protective lung ventilation strategy with the tidal volume of less than 8 ml per kg, they were able to bring down the incidence of acute lung injury, atelectasis, and ICU admission significantly lower than the historical controls. And besides, higher tidal volume have been associated with higher inflammation levels as well as extravascular lung water. But the tidal volume will only show improved oxygenation when used with adequate PEEP. Otherwise, it will worsen the oxygenation. The calculation of tidal volume should be based on the predicted body weight. Now, is the PEEP always beneficial? Yes, the PEEP is beneficial only if the resting intrinsic PEEP in the patient is well below the lower inflection point in the compliance curve. So if our PEEP serves the purpose to bring the patient to the level of the lower inflection curve, then definitely the PEEP is going to help. But in the patients with COPD, where the patient already has an auto PEEP, and any extra addition of the PEEP will take the patient away from the lower inflection point and will lead to over distension, as well as divert the blood away from the lung to the non-ventilated lung, which is going to be counterintuitive. The next thing is that a PEEP titration should be done to the lowest driving pressures. This is a concept which has found place recently, and ventilation is being based on the driving pressures. Now, driving pressure is nothing but the difference in the peak pressure, the plateau pressures and the PEEP, or the tidal volume divided by the compliance. So a driving pressure less than 15 centimeters of the water is what we are targeting. So this is how the graph looks like in a normal patient. In a spirometry, the inspiratory flows, then the expiratory flows, and it comes down to zero level. But in a patient with autoped, the expiratory flows, they have a spoon-shaped curve and they never come down to the zero level, and the next cycle again starts. Another reason to give PEEP is and keep the patient near the FRC is because of the pulmonary vascular resistance, which is the least at the functional residual capacity. If you go lower than the functional residual capacity, the pulmonary vascular resistance actually increases because of the increase in resistance due to larger vessels. And away from FRC, if we go above the FRC, the pulmonary vascular resistance increases because of increased resistance in the small vessels. So another reason to give PEEP and bring the patient to as close to the FRC as possible, so that we have a better ventilation and perfusion match. As regards the FiO2, we have to titrate the FiO2 to the lowest level so that we achieve the acceptable SpO2 of 92% and thereabout. So any SpO2 above 92% is unreasonable if it needs a higher FiO2. So we initiate one lung ventilation at a higher FiO2 of 0.8 to 1, and then probably titrate it to the lower levels according to the SpO2. Higher FiO2s generate free radicals, and pro-inflammatory cytokines are released. Oxygen toxicity can also result from ischemia reperfusion injury using high fraction of oxygen, which ultimately leads to increased rates of respiratory failure and cardiac arrhythmias and pulmonary hypertension. So unnecessary high FiO2s are not beneficial, rather they are harmful for the patient. The next thing is alveolar recruitment maneuver, which we have already discussed, that recruitment maneuver should always be given at the beginning of one lung ventilation, but further recruitment maneuver should only be given as indicated by declining oxygen saturation and or by declining the compliance. So If giving a recruitment maneuver gives an improvement in oxygenation or lung compliance, then probably the PEEP that we were using was inadequate and we need to go up on PEEP levels. And consistent higher levels of PO2 have been found after alveolar recruitment strategy compared to before alveolar recruitment. Besides, as part of the pulmonary protective ventilation strategy, it served the purpose to decrease the incidence of post-operative pulmonary injury. As regards the ventilation modes, the peak airway pressures, plateau pressures, and pulmonary shunt, they have been found to be significantly higher during volume control ventilation, vis-a-vis the arterial oxygen tension, which was significantly higher during pressure control ventilation. Also, the newer mode of ventilation, that is PCV-VG, has been found to be better compared to volume control ventilation as regards the peak airway pressures and the oxygenation. Permissive hypercapnia is one of the central components of protective ventilation strategy, and the humans have a remarkable tolerance for extreme hypercarbia because of its beneficial effects on cytokine levels, apoptosis, and free radical injury, and it also potentiates the hypoxic pulmonary vasoconstriction. The IE ratio and respiratory rate should be set according to the patient profile. So a patient with a COPD would probably need a higher expiratory time compared to those with restricted diseases, but a higher respiratory rate should be kept with keeping in mind that it has the potential to generate auto-PEEP, dynamic hyperinflation, and may increase the dead space ventilation. The peak, we should strive to keep the peak pressures less than 40 and plateau pressures less than 25. As Lee et al. Found that a threefold increase in the risk of acute lung injury with the plateau pressures of 25 compared to a plateau pressure of 15 centimeters of water. As I said, driving pressure application to guide the ventilation has been found to be a better parameter compared to traditional protective ventilation in decreasing the incidence of post-operative pulmonary complications. Now, during the maintenance of anesthesia, with the advent of newer volatile anesthetics which have least effect on the hypoxic pulmonary vasoconstriction, like desflurane and sevoflurane, the immunomodulatory effect actually has been found to be beneficial in one lung ventilation because as compared to propofol, they have been found to decrease the cytokine elevations in either of the lung in bronchial lavages. Now, another thing that can happen during, apart from acute lung injury, a complication that can happen during one lung is the hypoxemia. Although the incidents have come down due to better understanding of the one lung physiology, better lung isolation, and newer volatile, but still there are certain conditions where we can predict the patients who are going to land up in hypoxemia, and these are if the patient has had a prior contralateral resection, has normal lung function pre-op, or has been on chronic vasodilator therapy, which will hamper hypoxic pulmonary vasoconstriction. If he has a poor oxygenation pre-op or on two lung ventilation or is in sepsis. Besides a surgery on the right side in supine position, and those patients requiring a higher or deeper anesthetic will most probably land up in hypoxemia. So what do we do once the patient has hypoxemia? So the action will depend on the urgency of the situation. If it is severe and precipitous desaturation, we'll immediately resume two lung ventilation if possible and give 100% oxygen. However, if it's a gradual desaturation, then we ensure 100% oxygen and check the position of the double lumen tube or blocker, make him hemodynamically stable, give recruitment maneuver, increase the PEEP to the ventilated lung, give oxygen insufficient in the non-ventilated lung, and apply CPAP to the non-ventilated lung if possible, or give partial ventilation like lobar insufflation or selective lobar collapse using a bronchial blocker. If these methods fail, we can resort to pharmacological manipulation. If none of these work, then we can ask the surgeon to manually restrict the blood flow to the non-ventilated lung, either to through a segmental artery or a lobar artery, or if the patient is undergoing a pneumonectomy, probably the main pulmonary artery also. If nothing works, then probably we'll have to resort to veno-venous extracorporeal membrane oxygenation. So this is the CPAP circuit where there's a PEEP valve which we can adjust according to requirement, and we can attach oxygen tubing. And this is how we give a lower insufflation using a fiber optic bronchoscope. We can guide the fiber optic to the lobe where we want to insufflate and connect an oxygen tubing to the suction port. Now from the one lung to the extubation, when the patient surgery has been done with and the surgeon wants you to re-expand, this re-expansion serves the purpose to restore the normal lung and normal lung volume and minimize any post-operative pneumothorax and restores the VQ matching. But in doing that, we should be cautious that we do not disrupt the staple lines or make the patient unstable in the face of commonly practiced relative hypovolemia in these patients. Now, blowing up both the lungs at the time of resuming two-lung ventilation may not be necessary because it will cause over-distension and volume trauma in the more compliant non-operative lung. So what we can do is we can do a selective lung re-expansion with either a second circuit or a transient isolation of the non-operative lung and put all the targeted pressure to the elected operative lung. The lung can again suffer lung injury due to ischemic reperfusion injury. So lower FiO2 should be employed as a hypoxemic reperfusion has been shown to attenuate the inflammatory response and organ injury. Now this is about the one lung ventilation. So what are the options available to achieve one lung isolation? I'll just run through these options. So these are the options: double lumen tube blockers and single lumen tube or univent tube, with all their advantages and disadvantages. Like double lumen tubes is considered the gold standard. It's the quickest to place and doesn't always need a bronchoscope to place. However, the disadvantages are like the sizes are limited and there's a lot of potential for airway trauma. The bronchial blockers, they have the advantage of being available in many sizes, and we can do a selective lobar isolation also with these. However, suction is not possible. It always needs a fiber optic bronchoscope to place, and more time is needed for insertion. Working knowledge of the tracheobronchial anatomy should be known to the anesthesiologist, with the trachea dividing at the carina into the right and the left mainstem bronchi, and the right gives away left right upper lobe, middle lobe, and lower lobe bronchi, and the left gives left upper and left lower. You can appreciate here that the right upper lobe bronchus offshoots pretty quickly at about 2 to 2.5 centimeters. So there's a very low margin of safety in placing the tube. And on the left side, we got a good margin of safety. And this is about 5 centimeters. So this is the right side DLT with the donut shaped cuff and the slot for right upper lobe. This is the left side DLT. You can appreciate the diameters in the cut section of 8 size and a 35 size. So although it's just a 35 French, but it's much bigger than a 8 size single lumen tube. There are various methods by which you can assess the size of the tube inserted, but the one method that has been found to be most appropriate is based on the tracheal diameter measurement, either from the chest X-ray or the CT. So this is the you should always check your DLT placement with a fiber optic, because the incidence of malpositions have been in the tune of 30 to 70%. Even when clinically correctly placed. So this is the view that you obtain after a left DLT insertion from the tracheal lumen. You should be able to see the tube going onto the left side and a clear view of the trifurcated right upper lobe. And from the left lumen or the bronchial lumen, you should be able to see the upper and the lower lobe on the left side. Similarly, you should make confirmation on the right DLT also. This is a Viva side DLT, which has recently been launched by the Ambu, which has a camera inculcated just opposite to the tracheal lumen, and you have the view of the carina and the left-sided lumen all the time inside. So any displacement or malposition can be immediately corrected. These are the blockers that can be used. The ARNT blocker with the loop to hook the fiber optic bronchoscope, coherent tip deflecting blocker, uni blocker, and this is a bifurcated tip EZ blocker. This is a Kubdeck blocker, which is being used at our place. This is the univent tube, and these are the bronchial blocker characteristics, which I'm not going into the details of. So a skill set, finally, the skill set that is required for a successful one lung ventilation management is a thorough knowledge of the one lung physiology, familiarity with the isolation devices, a skill with the fiber optic bronchoscope, and a working knowledge of the radiological and fiber optic tracheobronchial anatomy. Now, a couple of scenarios here. So a 60-year-old male who has a lung cancer, smoker, undergoing a left thoracotomy for a left upper sleeve lobectomy, has had a right-sided DLT placed. Uneventful one lung ventilation went on till the hilar dissection, and suddenly the pressures increased to 40 centimeters of the water and the tidal volume dropped. Although the vitals were maintained, but there was gradual drop in the SpO2. So what do you think could be happening here? So most probably, if we put in a fiber optic, we would realize that the right side DLT has got dislocated because of the hilar manipulations. So it just needs repositioning and everything should be fine. So another scenario where the obese 70-year-old male hypertensive is undergoing VATS for a left lower lobectomy for neuroendocrine tumor. You have initiated a one lung ventilation with routine protective lung strategy. Your colleague gives you a break, and once you return after say 15 minutes, your colleague tells that the SpO2 dropped from 95 to 89%. So increase the tidal volume to 550 and FiO2 to 100%. So SpO2 is now 100%. Has he done the right thing? So maybe, although the saturation is okay, he may not have done the right thing in increasing the tidal volume to such high levels. So after 15 to 20 minutes of the initiation of one lung ventilation, the oxygen levels, they reach their nadir, and a little bit of drop in saturation is expected at that time. The thing he could have done was increase the FiO2 and then check for the reason for hypoxemia, rather than going on to increase the tidal volume and just making sure the SpO2 comes up to 99%, which is unnecessarily. The initial settings were perfect, just a increase in FiO2 was needed. So coming back to that picture again, so if this person is the patient who is undergoing one lung anesthesia tightrope, then probably the pole in his hand will be the anesthesiologist, who is going to keep him in balance with his knowledge and wisdom, and giving him a smooth glide through to safety. So I leave you with this thought that it is better to prepare and prevent than to repair and reprevent. Thank you.
Thank you, Sudhir, for such an extensive and exhaustive talk. I think you covered the topic quite well on one lung anesthesia and what are the problems that can be associated and how it can be prevented. So from this, we go on to our next speaker. Our next speaker is Dr. Das, who's going to be talking about, the thing which is of more real concern for us, that is the fluid management in our patients who are undergoing thoracic surgery. So he's going to talk about the perioperative fluid management in thoracic surgery, streamlining the intricacies. Dr. Das is again a principal consultant with us at Medanta. His areas of interest include safety in anesthesia. Over to you, Dr. Das.
Yes, thank you, ma'am. And I would like to thank you, ICA, for giving me this opportunity to speak on the topic of perioperative fluid in thoracic surgery. So why we are discussing fluid in thoracic surgery patients? Because we are really scared of giving fluid. We don't want to induce a post-operative pulmonary complication by giving excessive fluid, because the lung is recently being injured by the one lung ventilation, by the surgical team, by lung resection, and that ischemia reperfusion injury. And on top of that, there is a risk of post-op pulmonary edema, difficulty extubation, re-intubation, and cardiac dysfunction. So we feel that our 1 liter of crystalloid is going to drown the patient as well as the lung. So before going to the presentation, I would like to discuss this slide about the revised Starling equation and the concept of extra endothelial glycoklerics layer. So on the left-hand side, we can see that there is a classical Starling principle where the fluid transition from the endothelium, from the capillary to the interstitium, is governed by the Starling forces, like interstitial hydrostatic pressure, as well as the oncotic pressure in the capillary and as well as in the interstitium. This was the original Starling principle, But then the glycocalyx concept came into place. In the middle picture, you could like to see that in the capillary, inside the capillary, there is a constant layer of endothelial glycocalyx. And the new concept has taken into consideration the fact that the hydrostatic pressure which governs the exudation of fluid into the interstitium is the same. But that colloid oncotic pressure difference is interacting between the capillary, inside the capillary and the subglycocalyx layer. It's nothing to do with the interstitial oncotic pressure. And whatever fluid is coming out from the capillaries into the interstitium is being taken out back to the circulation by the lymphatics. Initially, the concept of lymphatics was not much. People used to give hypertonic salines, hypertonic colloids, so that in an anticipation that whatever fluid is coming out to the interstitium will go back to the circulation by increasing the oncotic pressure inside the lymphatic, inside the capillaries. But it is not happening, because now the concept is whatever fluid is coming to the interstitium will go back by the lymphatics only. And when this glycocalyx is being damaged by whatever reasons, this damaged glycocalyx will lead to a great flow of fluid into the interstitium, and that lymphatic circulation will take care of that till 7 times of the normal lymphatic circulation. They can increase their flow till 7 times, but beyond that, what will happen is that their interstitial fluid will go into the pulmonary alveoli and cause pulmonary edema. So the endothelial glycocalyx plays a key role in the endothelial barrier function and lung injury, and is destroyed by hypovolemia or hypervolemia or rapid large volume challenges or acute hyperglycemia, surgery or sepsis. All these factors are present in any surgery, but more in case of a thoracic surgery. So from that glycocalyx model, we could understand that the colloid only behaves like a colloid when vascular endothelial glycocalyx is intact and patient is not hypervolemic. And same amount of fluid, whether it's a crystalloid or colloid, administered to a hypovolemic patient will be retained in the intravascular space, but will be filtered to the interstitium in a hypervolemic patient. Acute lung injury can happen in thoracic surgery. It ranges from simple acute lung injury to the extreme form of ARDS. And the incidence is around 2.5% in all lung resections, but it can go up to 7.9% in case of a pneumonectomy. And in the diagram, we can see one lung ventilation leads to lung injury by various factors, like Dr. Sudhir has already discussed. It can act on the ventilated lung. It has, and the non-ventilated lung also is injured because of the various perfusion, reperfusion injuries and inflammation. Here you can see 2 X-ray pictures of re-expansion pulmonary edema, and the other one is post-pneumonectomy, ARDS. What type of fluid we should use in our thoracic surgery patient is a little controversial, but we need to define the context. At what context we are giving fluid, whether the patient is hypovolemic, whether the patient has needs some resuscitation fluid or some maintenance fluid, whatever the context is, the fluids will behave in that manner only, and what time we are giving the fluid. We should remember that the dose makes the poison. If we if you overperfuse any kind of crystalloid or colloid over its permissible limit, it is going to be a poison. And it is better to mix our use of fluid like crystalloid, colloid, or albumin with judicious transfusion triggers. For primary maintenance, obviously, we use a isotonic balanced crystalloid with high strong ion difference, because we know that excessive colloids has the potential to cause acute kidney injury, coagulopathy, and anaphylaxis. Albumin is an alternative to synthetic colloid with lesser nephrotoxicity. And various articles has shown that colloid therapy with albumin improves PaO2 by FiO2 ratio, but not the survival in patients of ARDS. In the SAFE trial, they failed to demonstrate any difference between 4% albumin and saline therapy in a variety of outcomes in a mixed population of critically ill patients. So a combination of crystalloid and colloid, well within the maximal limit, was found to be safe in various studies. Need to maintain the organ perfusion pressure. So in this article, we can see that provided that the fluid overloading is prevented, the type of fluid does not matter. It does not cause any loading and does not affect the pulmonary permeability and edema. So the overloading should be avoided. So coming to the protocols, what are the different protocols that are available for fluid therapy in our thoracic surgery patients? There is no clear definition of restrictive or liberal fluid therapy in thoracic surgery. So whatever definition we can get from our non-thoracic patients, we can take it into consideration. Like restrictive fluid therapy can be defined as a transfusion of less than 1.75 liter per day, balanced between 1.75 to 2.75, and liberal more than 2.75 liters per day. First, let's talk about the liberal fluid therapy. So preoperative, why people used to give liberal fluid? Because they thought that preoperative fasting, vomiting, blood loss, hyperthermia, diarrhea, bowel preparation, etc. can lead to hypovolemia. And they used to replace the third space, which is now obsolete. And fluid administration to achieve optimal oxygen supply and tissue perfusion was the protocol. They used to give more fluid so that the stroke, the perfusion is better, and indirectly the tissue oxygenation is better. So this is the Frank Starling curve. This where we can see that people try to achieve the stroke volume to a higher range by giving transfusing fluid. So that they thought that by keeping the patients in the higher part of the curve, so that the tissue perfusion will be better. So various studies had used different amounts of fluid. In the liberal group, this is a relief trial where at the induction time, they used 10 ml per kg of Hartmann solution. During surgery, 8 ml per kg per hour. And after surgery, they used more than or equal to 1.5 ml per kg per hour till more than 24 hours. And what they found in the relief trial, they found that the regime that includes a modestly liberal administration of fluid is safer than the restrictive regimen. And acute kidney injury occurred in 8.6% in the restrictive fluid group and 5% in the liberal fluid group. However, this demonstrated an increase in plasma angiotensin 2 and soluble intercellular adhesion molecule 1, suggesting endothelial lung injury with the higher fluid volume. Although they found that the kidney injury is less, the lung injury is more. And little bit about the restrictive fluid therapy. This concept of restrictive fluid therapy started because in the year 1984, Dr. Geldin, this is a very famous paper where he identified 3 significant risk factors for post-pneumonectomy pulmonary edema. One is right pneumonectomy. 9 out of 10 cases develop post-pulmonary pneumonectomy pulmonary edema, increased perioperative intravenous fluids, and increased post-operative urine output. These are the 3 factors that he identified. Subsequently, and he said, the most important thing that we can do in terms of recognizing this problem of post-pneumonectomy pulmonary edema is to watch our anesthetists as they start loading the patient up with fluid. So once he observed this concept, various other researchers have found that in the no lung injury groups, patients received significantly less amount of fluid as compared to the lung injury groups. These are various publications that they have reported a better advantage with a restrictive fluid regime. But the risk of AKI after lung resection surgery ranges between 6 to 33%. And in the relief trial also, they observed that 8.6% in the restrictive fluid group and 5% in the liberal fluid group, because that AKI, acute kidney injury, can in turn lead to ALI. We can see in this diagram, if a minor form of, say, not so major kidney injury happens, this leads to a lot of inflammatory substances to be released into the circulation, which ultimately affects the lung and causes increased inflammation and non-cardiogenic pulmonary edema. On the other hand, if the patient goes into loss of kidney function, then there will be metabolic acidosis and decreased cardiac output, and this will lead to increased cardiogenic pulmonary edema and inflammation. There is this paper in circulation 2009. They have shown that in thoracic surgery patients, the incidence of AKI is around 33%. And when they followed those patients for recovery, complete recovery was possible only in 60% of the patients, and 3% patients did not have any recovery from their AKI. And when they followed these patients till 10 years, they could see that the AKI patients had less survival percentage than the non-AKI patients. This report published in Nature journal, where they, in thoracic surgery patients, they divided patients into 3 groups, low, cutoff, and high. What they found that maintaining intraoperative net fluid infusion of 4 to 5 ml per kg per hour was associated with better results in open thoracotomy in terms of composite complications. So what they found is that this is the composite complication curve. In the cutoff group, there's a least amount of composite complication as compared to the low fluid group and the high fluid group. Similar is the incidence in pulmonary complications and ARDS and bronchopleural fistula. The case of zero fluid balance, zero fluid therapy, extreme form of fluid restriction protocol is the zero fluid therapy. Only the fluid that is lost during surgery is replaced. No preloading, no third phase replacement, intended to minimize the post-operative weight gain. Problem with zero fluid balance concept is that the definition of zero balance is not clear, confusingly used with fluid restriction strategy and difficult to follow intraoperatively. Risk of organ hypoperfusion and hypovolemia is there. So till now, what we have learned, that conclusion till now is that what is good for the lung is not good for the kidney, and it is important to avoid too much fluid. This is sure. The evidence of severe restriction or zero balance is not so clear, not so strong. And fluid administration for the other option is a goal-directed fluid therapy. So various parameters are being used for goal-directed fluid therapy in thoracic surgery patients. And various reports has shown that goal-directed fluid therapy is good in thoracic surgery patients, like PaO2 FiO2 ratio has improved, and the patient did not have any increase in the extrathoracic lung water. As in this article, we can see that goal-directed fluid therapy, the pink line, maintained the creatinine at a normal range, whereas the restrictive fluid therapy made the patients a little high on creatinine in the post-op. And the central venous oxygen saturation concept, again, it's quite stable in the goal-directed fluid therapy patients. But it has certain limitations. Like we all know that stroke volume variations and pulse pressure variations are relatively inaccurate in thoracic surgery because of the patient is open thorax, and then patient has low tidal volume because of the protective lung ventilation and all, and it risk of arrhythmias. So positive fluid response, one important concept that we should understand, that a positive fluid response does not necessarily mean that the patient is too hypovolemic. Like in this paper, they have found out that when a passive leg raise test was done in well-hydrated volunteers, they also showed an improvement in the stroke volume by more than 10%. That does not mean that patients were hypovolemic. And in that process of stroke volume optimization, we keep on giving fluids boluses till the patient is at the higher end of the Frank-Starling curve. But by that time, a lot of fluid has gone into the patient, which might not be good for a thoracic surgery patients. And if the fluid level goes up a little more, then we enter the Merrick-Phillips curve, where the extravascular lung water component goes up. So in this editorial in Anesthesia, the editor said that we are measuring stroke volume and trying to optimize it to get the maximal oxygen delivery to the tissues, but stroke volume is a surrogate of tissue oxygenation. We hope that our hemodynamic interventions will optimize oxygen delivery without measuring it. So what will be the best fluid management option? Probably we should define the zero in zero balance first, and define the goal in our goal-directed fluid therapy. Define the liberal and definitely avoid it. Define the euvolemia, and probably it's best to follow it. So in the relief, so we can see that the restrictive for some can be liberal for others. It's in the eye of the beholder. Because the intra period is unique. The intra, because of the effect of the anesthetic agents, because of the surgical manipulation, surgeons will be pressing on the lung, on the heart, on the vascular structures. So individuals move. A particular person does not follow a particular ventricular contractility curve, function curve. The same patient will be in different ventricular function curves at different points of time. So it is very difficult to be sure what optimum stroke volume is the person is in. So the ERAS protocol was introduced by the European Society of Thoracic Surgeons. What they have said, we all know about ERAS, but then this is for the fluid therapy class. This is very important because clear fluid should be allowed. What they recommended was clear fluid should be allowed up until 2 hours before induction of anesthesia, and solids under 6 hours before anesthesia. And oral carbohydrate loading should be given. And during the perioperative fluid management thing, there's a written that very restrictive or liberal fluid regime should be avoided in favor of euvolemia, and balanced crystalline solutions should be given, and intravenous fluid should be discontinued as soon as possible. So what they said is that bring your patients to the OT in the euvolemic state by reducing the fasting period, and maintain the patient in the euvolemic state, and use only the balanced crystalline solutions over 0.9% saline. And they said that if we follow the ERAS surgical pathway, the patient will be in the euvolemic range throughout, rather than deviating from the hypo to the hypervolemia, as we can see in the traditional surgical pathway and in the blue curve. So again, we are very skeptical of giving fluid in our pneumonectomy patients because we think that it's going to be harmful. But we should understand that post-pneumonectomy pulmonary edema is a multifactorial thing. The most probable causes are fluid overload, lung lymphatics, pulmonary capillary pressure, pulmonary endothelial damage. All these things are probable causes, and possible are volume-induced lung injury and right ventricular dysfunction. So here, fluid overload is an important factor. It is true, but then the other factors like pulmonary capillary pressure is also playing some role. And pulmonary capillary pressure is in, we should be aware of the fact that pulmonary capillary pressure does not go up too much after pneumonectomy because of the recruitment of the capillaries, and it has been shown that until and unless the left atrial pressure is doubled, the pulmonary capillary pressure is not going to change much. So not all increases in pulmonary pressure post-operatively are related to intravenous volume, intravascular volume. Other factors under the influence of the anesthetist, such as hypercarbia, hypoxemia, and pain, can also increase pulmonary pressures and must be treated. So moderate fluid restriction targeting near normovolemia, individualized of course, is safe in pneumonectomy and no need for dry as a bone patient. So if someone asks us what is the safe infusion rate, it's very difficult to say, but a particular rate of infusion goes against the individualized approach principle. But still, these articles have shown that the safe limit is 6 ml per kg per hour. As you can see in the diagram, the pulmonary complications has gone up after 6 ml per kg per hour. If we infuse more than that, the pulmonary complication goes up. And less than 2 ml per kg per hour also, the pulmonary complication goes up. So the sweet spot is around 5 ml per kg per hour. In the Nassar journal, also in the thoracic surgery patients, the article also said that 4 to 5 ml per kg per hour was associated with better results in open thoracotomy. And so does the vasopressors has some role in fluid management? Yes, they have some role because they modulate the capillary hydrostatic pressure. So the appropriate use of vasopressors can lead to fluid reduction in the fluid infused volume, because you can see here, this is the normal capillary on top, and on the left side is a dilated capillary. Once the capillary is dilated because of the effect of anesthetics and all, what happens is the hydrostatic pressure inside the capillary goes up, and the rate of fluid exudation into the interstitium is more. So if we use some vasopressor at this point, the capillary bed will be narrowed and the hydrostatic pressure will be reduced again. So the fluid exudation will be less, so less amount of fluid might be needed. And in the collapsed capillary, again, if the patient is hypovolemic and the capillaries are collapsed, if we give inotropes at the vasopressor at this point, there will be a deleterious effect and the tissue perfusion will be affected. Here, patient needs some volume. So what are the observations? Liberal, standard, or restrictive, it's in the eye of the beholder. Definitions vary in literature, so will be the outcome of interpretation. So the important thing is perioperative fluid therapy should be individualized, and individualization of fluid prescription needs to take into account the gender, age, complicating illnesses, cardiac and renal function, body composition of the patients. All patients are different, so everyone needs a individualized fluid therapy approach because one size does not fit all. So a concept that we should probably follow is that we should, rather than fluid therapy, it's a fluid et al. Approach that we should probably follow, because it's the multi-hit that causes all the damage. Fluid is just one factor. So target should be a stable hemodynamics and euvolemia. So along with a euvolemics patient, we should always take help of the other factors which is going to impact adversely or favorably the fluid management protocol. Like we should take care of the ERA's recommendations about preoperative fasting and intra-op management. And we should take help of the protective lung ventilation strategy, because if the lung ventilation strategy is not good, it's anyway going to create an inflammatory response and damage the glycocalyceal layer, and ultimately will affect the fluid volume, fluid therapy And use of mixed fluid regime, like not only the crystalloid, not only the colloid, we can use also albumin and free FFPs to minimize the dose of individual agents, and a use of vasopressors because of the anesthetic effect, vasodilating effect. We can use little bit of vasopressor so that to nullify the effect of anesthetics rather than giving fluid, because the patient is not actually probably not hypovolemic but relatively hypovolemic. So even a reasonable fluid protocol will be harmful if multi-hits are allowed. So fluid et al. Approach encompasses many such protective steps. In the words of Dr. Slinger, he said, we can make the lung injury worse, but we do not cause it. And finally, I would like to say that we should preserve the endothelial glycocalcium layer, because this J point is important, where the rate of infiltration of fluid into the interstitium starts basically. And if the patient endothelial glycocalcium layer is injured, then this point is shifted towards the left. So lesser amount of fluid will cause infiltration into the interstitium rather than, and the J point should always be maintained. And for that, we need to preserve our endothelial glycocalix by euvolemia and by whatever means available, like protective lung ventilation and mix of crystalloids and colloids and all. Thank you.
Thank you, Dr. Das. I think the intricacies of fluid management have been very well discussed. And now we come to the end on the last talk of today, which is on the newer post-operative pain management in our patients who are undergoing thoracic surgery. For that, I'd like to invite Dr. Dinesh Singla. Dr. Dinesh, you can start sharing your slides. Dr. Dinesh is a senior consultant with us at Medanta, and his areas of interest include thoracic anesthesia, onco, and regional anesthesia. He has many publications and awards in his place, and he's also involved with the DNB program. Over to you, Dr. Dinesh. We cannot hear you, Dr. Dinesh.
Am I audible?
Yeah, you're audible now.
My topic of discussion will be the newer block for post-operative pain relief in the VATS surgery. So VATS is a minimal invasive surgery. It can be used for both for the diagnostic and therapeutic procedure for the structure present in the thoracic cavity. So it has a long history back. Jacobius first used the cystoscope to visualize the peripleural cavity in 1910. In 1990, there was a sudden increase in the minimal invasive procedure because of various advancements in the techniques, like miniaturization of video equipment, enhancement in the quality of picture and light source, and improvement in the lung isolation techniques, and introduction of the staplers for the surgical help. One of the main benefits propagated for the VATS surgery is the reduced pain. But the studies have shown that many patients experience moderate to severe pain in VATS surgery also. Reported incidence is 15% to 59%. Various risk factors like young age, increased BMI, history of smoking, and pre-existing pain has been identified as risk factor for post-operative pain. VATS surgery is mainly done by creating a 3 ports. One is the main utility port, which is created in the second or third intercostal space in the anterior axillary line, and 2 assistance ports are created in the 7th or 8th intercostal space in the posterior axillary line. So anesthesia should be multimodal, as in the case of any surgery. In systemic anesthesia, we have the choice of paracetamol and other NSAIDs like ketorolac. Opioids like morphine, tramadol, or fentanyl can be used. And alpha-2 adrenergic agonists like clonidine and dexmedetomidine has also been reported to show beneficial effect in controlling the post-operative pain in VATS surgery. Today we will be focusing more on the regional anesthesia. In regional anesthesia, we have choices like thoracic epidural, paravertebral block, erector spiny plane block, serratus anterior plane block, and interpleural block. Thoracic epidural, as we know, is a gold standard for pain management in the open thoracotomy procedure. But for the bad surgery, it's a little too invasive. It has also inherent limitation like causing the hemodynamic instability, urinary retention, and risk of dural puncture and cord injury is always there. Thoracic paravertebral block is a technique of injecting local anesthetic close to the spinal nerves where it comes out from the intervertebral foramen. It produces a unilateral, segmental, somatic, and sympathetic nerve block. It was first described in 1905 by the Hugo Selhem, and it was quite popular in the early 1900s, but then went out of favor because of no reason reported. But it was rediscovered in 1917 by the Eisen and Wyatt, who published the utility of catheter in paravertebral nerve block. Since then, several authors have reported its benefit in various surgeries for controlling the post-operative pain and also for the thoracic procedures. It can be used to provide analgesia in thoracic procedures lateral to the paravertebral muscle. It can be used for open thoracotomy as well as for wide surgery, and it provides good pain control in breast surgery also. It can also be used as a sole anesthetic technique for certain high-risk patients for breast surgeries. The area of interest in this block is this triangular-shaped space, the paravertebral space. It is bounded medially by the vertebral body and the intervertebral foramen, and anterolaterally by the parietal pleura, and posteriorly by the superior costotransverse ligament. It communicates medially with the epidural space by the foramina, and laterally with the intercostal space. Superiorly, it communicates with the cervical paravertebral space, and inferiorly with the origin of psoas major muscle. It can be given by both classic as well as by ultrasound guided technique. In classic technique, needle is inserted blindly 2.5 centimeter lateral to the posterior spinous process to hit the transverse process. After hitting the transverse process, needle is withdrawn and advance corded to the transverse process till loss of resistance is felt. After achieving the loss of resistance, local anesthetic is injected. By ultrasound guided technique, it can be given in any position like sitting, lateral, or prone. Probe, both high frequency linear or curved probe, can be used according to the patient body habitus. It is held in the sagittal orientation, and needle usually taken is 5 to 10 centimeter long. It's a classic ultrasonography picture of the thoracic paravertebral space, which can identify the transverse process on the both sides and hypoechoic bright shining pleural line. Superficial to the pleura is a triangular paravertebral space, which is bounded anterolaterally by the pleura, medially by the transverse process, and posteriorly by the superior costotransverse ligament. It's a small video where parietal pleura is dissected close to the surgical incision site by the surgeon. After dissecting out the parietal pleura, catheter is placed in the paravertebral space and the pleura is stitched back. These are the video study which have compared the paravertebral block with the no block and for the rescue analgesia intravenous PCA morphine was used. They have shown the lower pain score and less upward congestion and significantly less side effects like nausea and vomiting in the study group. Complication of this block as pleura is nearby, it can always be punctured and pneumothorax can occur. Injury to blood vessel can lead to hemothorax. Chances of intrathecal injection is there, and obviously allergy to local anesthetic and local site infection can be there. Next is the interfacial plane block, that is rectus spinae plane block. Here our target of interest is the superficial local anesthetic is injected superficial to the transfer process and below the rectus spinae muscles. Rectus spinae muscles are a group of muscles comprising of the spinalis, longissimus, and iliocostalis muscles. They run vertically from the occiput to the pelvic and sacral region, and from the transfer process and spinal process medially to the ribs laterally. In this block, we inject local anesthetic superficial to the transverse process. Here it blocks the dorsal rami of the spinal nerve. That is why it provides effective analgesia for the procedure on erector spinal muscle. And studies have shown its procedure spread also into the paravertebral region, where it acts more as a proxy to the paravertebral block. It spread laterally into the interfacial plane like a retrograde stratus anterior plane has also been reported. It's an image of the patient where 30 ml of local anesthetic along with the contrast was injected at the T10 level, and MRI was taken 45 minutes and 90 minutes after the block. They have shown spread of the local anesthetic from the T5 region to T12 region along the intervertebral foramina also, and epidural spread also was reported at this level. In an axial view, local anesthetic migration from the rectus spinae space to the paravertebral space and then through the foramina into the epidural space was also demonstrated. Distribution can be as wide as 8 segments in the thoracic, but it's limited in the lumbar region and it can be up to 4 segments. It can be given in any position, prone, lateral, or sitting. High frequency linear probe of both curved probe can be used according to patient body habitus, and both in plane or out of plane technique can be used to give the block. In the thoracic region, T5 is the appropriate level to give the block, where spread below and above can gives us the analgesia for T2 to T8 region levels. Identifying the space, probe is held slightly laterally initially, where the rounded rib structure is visible, and in between the ribs, hyperechoic pleural line is visible. Then probe is placed, then moved more medially till the more squarer and superficial transverse processes are visible, and pleura is either hardly visible or not visible at all. These are the pictures showing some problems in giving the blocks. If we are seeing just flat hyperechoic line, it means we are giving the lamina, and we have to move more laterally to appreciate the transverse process. And if we are seeing the rounded structure with pleura in between, that means we are lateral and seeing the ribs, and we have to move more medial to identify the transverse process. This is a real-time video where we can appreciate the transverse process, and top of it is a rectus spinae muscle, and superficial or rectus spinae muscle can be the other muscle like teres minor or rhomboid minor, according to the level where we are giving the block. Needle can be inserted from any direction, either cranially, caudally, according ergonomics of the operators. After hitting the transverse process, a small amount of local anesthetic, after performing the negative aspiration, small amount of local anesthetic is injected. We can see the lifting of the rectus spinae muscle from the transverse process, and then total dose is injected here. At the end of the procedure, we can see the broad stripe of the local anesthetic separating the transverse process and the rectus spinae muscle. The pleura is far away, but still pneumothorax has been reported with this block. Other complication can be local site infection, allergy, and failed block. Mauricio Ferraro first introduced this block in 2016, where he managed the thoracic neuropathic pain of 2 patients with this block. After that, a number of case reports and original articles have been published showing the beneficial effect of rectus spinae plane block. Sifty et al. And Liu et al. Compared a single shot rectus spinae plane block with no block at all, and shown that there is lesser pain score, less opioid congestion, less side effects in the study group. Comparing the rectus spinae plane block with paravertebral block, Zhao et al. Compared a single shot, and Takata compared the continuous facility in both the spaces, and they found the comparable results in both the groups. Coming on to the second interfacial plane block, that is serratus anterior plane block. Here our goal is to inject a local anesthetic either superficial to the serratus anterior muscle between the serratus anterior and latissimus dorsi muscle, or deep to the serratus anterior muscle over the wrist serratus anterior muscle is a fan-shaped muscle originating from the lateral chest wall from the first to 8th or 9th ribs, and then be inserted it onto the middle border of the scapula and superior and inferior angle of the scapula. The nerves targeted main area of interest are the lateral cutaneous branches of T2 to T9 of the intercostal nerves, which provide analgesia in the anterior lateral chest wall. Other nerves which are consistently blocked are the intercostal brachial nerve, long thoracic nerve, thoracodorsal nerve. Spread achieved analgesia achieved is T2 to T9 levels usually in the anterior aspect and the lateral aspect of the chest wall. It can be used for pain management in the open procedure, VATS procedures, and breast surgery, and also can be used for the pain management in post-mastectomy pain syndrome. It can be given in the either lateral position or supine position. Probe is held in the mid-axillary line in transverse orientation. In this block, high-frequency linear probe is used, and volume of local anesthetic is large, around 30 to 40 ml is used. This is a classic ultrasound picture of the serratus anterior plain block. Here on the both hand we can see the ribs, 5th and 6th rib, and between the ribs is a pleura, hyperechoic pleural line. On the top of the pleura is the intercostal muscle, and superficial to the intercostal muscle is the serratus anterior muscle, and superficial to serratus anterior is the latissimus dorsi. Our target is either to give local anesthetic superficial to the serratus anterior between the latissimus dorsi and serratus anterior muscle, or deep to the serratus anterior muscle between the intercostal and serratus anterior muscle. This is a real-time video showing the serratus anterior plain block. Here we can see the 5th rib and the pleural line on the both sides. Middle is advanced, and after confirming active respiration, a small amount of local anesthetic is placed, and after confirming the correct place, local anesthetic is injected, and we can see the separation of the facial plane. As we inject the local anesthetic, we keep advancing the needle so that widespread region of the blockade can be achieved. As a volume blocker, we're giving good amount of local anesthetic close to the blood vessels. The toxicity of local anesthetic is there always a possibility there. The puncture of pleura can lead to pneumothorax and possibility of flared blockage there. It was first introduced in 2013 by the Blanco et al., who gave this block in the 4 patients. They given both superficial serratus anterior and deeper serratus anterior, one on each side in each patient. And duration of analgesia achieved was around 10 hours with superficial block, around 5 to 6 hours with the deep block. These are the some of the studies which have compared the serratus anterior plain block with no block, and they have shown the good pain control, less opioid congestion, and less side effects like nausea and vomiting in the intervention group. Comparison of the serratus anterior plain block with ESP block, Gabella et al. And Finnerty et al. Found no difference between the two blocks, but Kensi et al. Has found that there was pain control and opioid congestion was better in the block in the ESP group, but as compared to the deep serratus anterior plain block. Next block is interpleural block, where local anesthetic is injected between the two pleural rear, visceral and parietal pleura. It was first introduced in the 1980s by the ESTED. It acts by the blocking of the intercostal nerves. It was initially reported to have beneficial effect in controlling the post-operative cholecystectomy pain. Kambam et al. In 1918 showed that interpleural analgesia is useful in management of post-operative pain in patients who undergo open thoracotomy. But a recent study by Ghee et al., who compared this block with the skin infiltration, have found no difference in the pain score and opioid consumption in both the groups. Other option can be the intercostal nerve block or wound infiltration, which can help in managing the post-operative pain for some limited duration after the surgery.
Thank you, Dr. Dinesh.
Thank
With this, we come to the end of all our talks. And I'd like to thank all these speakers for giving us a lovely insight into the topics. They were all very well covered. The seminar is now open for any discussions or questions that we have. Ma'am, do we have any questions or? For us, do we have any questions or anything in the chat box or something? Otherwise, we can.
We have checked the delegates chat. There is no question from their end, sir, till now.
Okay. Okay.
Yes, ma'am.
So we can ask ma'am if there is anything. Otherwise, we can. Can we ask Dr. Jayashree Sood ma'am if there is anything? Otherwise, we can end this webinar for us for the concluding remarks.
Ma'am, I am trying to unmute her. Ma'am, she's not accepting it, ma'am. We need to contact him for that, ma'am. Do you have her number with you?
Yeah, I just one
You
second.
can check it, ma'am, because
Yeah,
I am approving from my end, but
Okay.
not accepting.
Okay. Okay. Just let me ask.
Sure, ma'am.
She's coming. Haji.
Hi. Any questions, Sangeeta? Any queries? Thank you so much. Any queries from the in the chat box?
No, I asked for us. He's saying at present there aren't any queries. So if
Yes, ma'am.
No queries. Okay. Okay. Right. So, Sangeeta, would you like to just give a summary of what all has been done today so that then we can conclude after that?
Yes, ma'am. So today, basically, we were covering on thoracic anesthesia. So we started from the pre-op workup where Dr. Preeti told us the importance of why, just not one test, but it is all the three tests put together, the three-legged stool, why it is important when we are taking up the patient and assessing them for surgery, because it is not how he will do on the table, but it is the long-term outcome which is important for us. Hence, we should do a complete workup of the patients. This was followed by the intra-op management, which Dr. Sudhir and Dr. Das discussed the two important pillars of thoracic surgery, which is the importance of the duration and the kind of ventilation we use for our patients, and the fluid management, which drives our outcomes and the morbidity in our patients. And finally, we concluded it with a talk from Dr. Dinesh, who talked about the newer pain blocks, which are now available for us, which we should be using more than, our epidurals and paravertebrals. I think with the advent of ultrasound, these newer blocks should be guiding our post-op pain measures for our patients.
Thank you, Sangeeta. So this was a very important webinar, which was covering such important topics, starting right from the last one, which was the newer blocks, which all the students should know, and not only the students, but we as consultants are not very well versed with the ultrasound blocks. So I'm sure this lecture by Dr. Dinesh has gone a long way in really helping us out how to perform these blocks, and we should, because all this comes in the ERAS protocols when we talk about it, how we mobilize the patient faster, and that's why how it should be done. And the perioperative fluid, as Dr. Das said, so important that now is the time. This was it was discovered long time back with the pulmonary edema that was developing in these patients after pneumonectomy, and how we stressed upon that. And so also one lung anesthesia, of course, whenever it comes to thoracic and whenever we are doing thoracic anesthesia, it's such a challenge and it's so exciting for everybody. And so then the one lung anesthesia, all the modalities were covered. And then Preeti, of course, the most important thing whenever we start is the pre-op workup. So of course, for the consultants who have heard this webinar, yes, all the tips, take-home messages that were delivered by the consultants are very important. And for the students, of course, each and every step that was covered was so well covered by all these speakers. And I would like to thank, of course, firstly, Dr. Sangeeta for moderating the webinar, and then Dr. Preeti, Sudhir, Dr. Das, and Dinesh for the excellent lectures that we took. Thank you so much.
Thank you.
And
Thank you
thanks
so
a
much.
lot. Thank you so much. I can see you all, most of you are still in the OT, and thank you so much for contributing to the ICA webinars. See you all next week for the webinar again next Wednesday. Thanks a lot and good night.
Thank you.
Thank you.
ma'am.
Bye-bye. Bye.
Thank you so much, ma'am.
Thank
Take
you
care,
all.
everyone.
Thank you,
Good
and
night.
thanks
Thank
for
you for
us.
us.
Thank you very
Thank you
much.
for us.
Welcome,
We are
ma'am.
missing Shanish today. Thanks to him
Yes.
as well. Thank you. Bye-bye.
Thank you, ma'am.
Thank
Take
you.
care, everyone.
Bye. Bye. Bye.
Yeah, bye.
Thank you. Bye.